Very pleasant morning and hearty welcome everyone to the AICTE sponsored International E-Conference on Pharmacy Practice and Therapeutics organized by Nirmala College of Pharmacy, Atmakur, Mangalgiri, Andhra Pradesh in association with Vikes University USA and Mayong's University South Korea. I feel privileged to extend my warm welcome to the eminent speakers of today's conference, Dr. Adam Van Wort, Associate Professor in Pharmacology and Toxicology, Vikes University, USA, and Dr. Sitansu Shekhar Nanda, Associate Professor, Mayong's University, South Korea. It's my immense pleasure to give a brief introduction about our college. Nirmala College of Pharmacy is established and administered by the Society of Catechist Sisters of St. Anne, Hyderabad. It is a self-financed institution affiliated to Acharya Nagarjuna University, Guntur, Andhra Pradesh, India, and is approved by AICTE and Pharmacy Council of India, New Delhi, and accredited by NAC and approved under UGC 2F and 12B. The institution acquired All India NIRF rank with a band between 76 to 100 since 2017 to 2020. Our institution is offering Diploma in Pharmacy, B Pharmacy, M Pharmacy with 3 specializations in Pharmaceutics, Pharmaceutical Analysis, and Pharmacology, PharmD, PharmD Postbaccalaureate, and PhD courses with various infrastructure facilities to provide the best quality of pharmacy education. I feel proud to say that Nirmala College of Pharmacy always stood as a pioneer in conducting various useful and informative conferences like DST-sponsored National Conference and Pharma Quiz on Innovative Approaches in Pharmaceutical Drug Discovery and Development by using QSAR methods in 2018, DHR ICMR sponsored National Workshop on Newer Diagnostic Modalities and Therapeutics in Cancer in 2019, International Conference on Pharmacy Practice and Therapeutics in association with University of Findlay, USA in 2019. Our college has taken a leading role not only in academics but also in organizing various extracurricular activities like sports meet, cultural activities, and many other NSS activities like blood donation camps and health camps in rural areas in and around Mangalgiri. Our college has got Women Grievance Redressal Cell to ensure safety and security in working and studying environment for women. Many activities like career guidance and counseling for women, competitions on gender themes to encourage students to think about gender issues, celebration of International Women's Day are carried out as a part of this Women's Grievance Cell. I feel happy to share you that our institution received so far 70 lakhs worth projects and funds from AICTE, DST, ICMR, TB Association of India, etc. to enhance the infrastructure facilities to build up career-oriented skills and soft skills through conferences to our pharmacy professionals. Nirmala College of Pharmacy has been successful in providing and maintaining high-quality teaching and research in pharmaceutical sciences and also inculcating moral values in the students. I really feel blessed to be a part of this institution. Thank you. I feel honored to invite Chief Patron of the E-Conference, Reverend Sister K. Sundari, Provincial Superior, CSA, Guntur Province, to convey her opening remarks.
Good morning to all of you. It's indeed an acknowledgeable occasion to our Nirmala College of Pharmacy because it is conducting International E-Conference sponsored by AICTE in collaboration with Wilkes University, USA, Mayongji University, South Korea. I congratulate Dr. Abdul Rahman, the principal, and Sister Alfonsa, the secretary of Nirmala College of Pharmacy, and all the faculty members, along with the committees, for their initiation to conduct national and international e-conferences during this period of COVID-19. I am proud to say that this is the 7th conference that Nirmala College is conducting to enlighten the participating delegates with advanced medicine and its applications. I appreciate all the delegates for your interest in updating your knowledge, mainly innovating research ideas on nanomedicine and pharmaceutical technology and drug delivery, etc., during this conference. My best wishes to all of you.
Thank you, sister. I feel delighted to invite patron of the conference, Reverend Sister P. Alfonsa, Secretary and Correspondent, Nirmala College of Pharmacy, to give a welcome message.
I am very much delighted about AICT sponsored 2 days international e-conference organized by our Nirmala College of Pharmacy, Mangalagiri, Andhra Pradesh, India, in collaboration with the Wilkes University, USA, and Myongji University, South Korea. This international e-conference enlightened about 4 functions of health management, such as planning, leading, organizing, and controlling. I appreciate all the committee members of this international conference, and I welcome all the delegates for the active participation in this 2 days international conference. God bless you all. Thank you.
Thank you, sister. I feel privileged to invite convener Dr. Sheikh Abdul Rahman, Professor and Principal, Nirmala College of Pharmacy, to speak about objectives of the conference.
I am very much proud and happy that today we are organizing AICT sponsored 2 days international e-conference in collaboration with Wilkes University, USA, Myongji University, South Korea. In this regard, it is my privilege to invite President of our college, Reverend K. Sundari Garu, beloved Secretary and Correspondent, Reverend Sister P. Alfonsa Garu, Professor Dr. Adam Van Wort, Director, Department of Pharmacology and Toxicology, Wilkes University, USA, Dr. Sitanshu Sekhar Nanda, Associate Professor, Myongji University, South Korea, Coordinator, Dr. T. Vinay Kumar, Co-Coordinator, my friend, Dr. Ajay Brahma Reddy, Wilkes University, USA, Dr. Dwarakanath Reddy, Chief Editor, Journal of Global Trends in Pharmaceutical Sciences, Chairpersons, Dr. C.H. Babu Rao Garu, Professor and Principal, Priyadarshini Institute of Pharmaceutical Sciences, Guntur, Andhra Pradesh, Professor Dr. D. Narendra, Principal and Professor, VJS College of Pharmacy, Rajahmundry, Andhra Pradesh, all the committee members, my HODs, all the staff members, our Nirmala students, delegates, staff members of various institutions of India and abroad, research scholars, students, heartily welcome to the AICT sponsored International E-Conference. Coming to the key objectives of our e-conference is to illustrate innovative research ideas on nanomedicine, nanotechnology, pharmaceutical technology, drug delivery, medical devices for drug delivery biotechnology, nanorobots, and formulation technology. To deliver incredible research outcomes by international experts. To provide interdisciplinary platform to deliver and discuss about the most recent innovation trends as well as practical challenges encountered and solutions adopted in the field of nanomedicines and nanotechnology and also in advanced research. Coming to the plan of today's International E-Conference, upon completion of inauguration, scientific session 1 is conducted by resource person Professor Adam Van Wort, Wilkes University, USA, on oxalate homeostasis, kidney stones, research on oxalate transportation. In afternoon session, poster evaluation is going to be done by the scientific committee and external experts. Tomorrow, 20th August 2020, by 10 a.m. sharp, scientific session 2 by Professor Dr. Sitanshu Sekhar Nanda, Myongji University, South Korea, followed by announcement of prizes and closing remarks. Thank you one and all. Have a good day.
Thank you, sir. I extend my warm welcome to Coordinator Dr. T. Vinay Kumar, Professor and HOD Nirmala College of Pharmacy, to speak about relevance of the conference.
Dear all participants, a very good morning to all. First, I thank everyone who registered for this international conference and giving the positive vibes for us. It's my privilege being coordinator for this conference conducted by Nirmala College of Pharmacy. First and foremost, I want to convey my big thanks to AICT New Delhi for sponsoring this international conference and giving continuous support to our institution for improving R&D infrastructure. I wish to extend my gratitude to the management of Nirmala College of Pharmacy for allowing us to conduct this event. My heartfelt thankful to Principal Dr. Sheikh Abdul Rahman, convener of today's international conference. I thank the resource persons Dr. Adam Van Wort, Vikes University, USA, and Sitanshu Sekhar Nanda, Myung University, South Korea, for accepting our request and sharing their valuable time and knowledge with us. I would like to give the brief schedule of the conference. On the first day, we will be having the first session of Dr. Adam Van Wort, Vikes University, USA, in the morning session, and in the afternoon session, evaluation of e-posters will be conducted. And on the second day, another session of the second speaker, Dr. Sitanshu Nanda, will be conducted. After that, the prize winner of e-poster competitions will be announced. Meanwhile, during the both presentation, the feedback form will be displayed in the description box. Kindly fill the feedback form and submit your valuable suggestions. Live chat also will be enabled during the international conference, and participants can clear their doubts there itself. Thank you. Let us start.
Thank you, sir. I feel privileged to invite co-coordinator Dr. Ajay Bommareddy, Associate Professor, Vikes University, USA, for a welcome message.
Good morning, everyone. Welcome to the International E-Conference focusing on pharmacy practice and therapeutics, organized by Nirmala College of Pharmacy. My name is Ajay Bommareddy, and those of you who are seeing me might have recognized me from my earlier talk, where I was one of the speakers in the webinar series organized by Nirmala College. Today, I'm here again to talk to you and introduce to you one of my good friends and colleague at work, Dr. Adam Van Wort, who is going to present his research focusing on oxalate formation in kidney stones. Dr. Van Wort holds a PharmD and PhD and has been working in this area for several years and published multiple articles in well-known reputed journals. Dr. Van Wort and myself at work, we collaborate each other on multiple research projects. We co-teach in our PharmD curriculum, and currently Dr. Van Wort is also the director of our master's program in pharmacology and medicinal chemistry. Please reach out to him if you guys have any questions pertinent to his research or any other questions related to careers in pharmacy. Otherwise, enjoy the talk and post any questions that you might have during his presentation.
Thank you, sir. I would like to invite Dr. Sailendra Kumar, in charge of Innovation and Incubation Center, Nirmala College of Pharmacy, to introduce the chairperson of the session.
Hello everyone. I'd like to introduce to the delegates the chairperson for the International E-Conference on Pharmacy Practice and Therapeutics. The first session by Dr. Adam Van Wort, Associate Professor, Department of Pharmacology and Toxicology, Wilkes University, USA, would be chaired by Dr. Chandubabu Rao. He is currently the principal of Priyadarshini Institute of Pharmaceutical Education and Research. He is having 27 years of teaching and research experience. He has completed his MPharm in 1993 from Dr. MGR University, Tamil Nadu, and PhD in Pharmaceutical Chemistry from Andhra University in the year 2005. He is an honorary fellow member of Association of Biotechnology and Pharmacy. He is currently the member Board of Studies of Acharya Nagarjuna University, Guntur. He is a life member of Indian Hospital Pharmacy Association and Association of Pharmaceutical Teachers of India, along with being a joint secretary for JNTU University Pharmacy Principals Association. He is a recipient of the Best Pharmacy Teacher Award in the year 2009 from JNT University, Kakinada. He has to his credit more than 198 international and national publications. He has so far guided 15 PhD students, and his research interests include phytochemicals, their formulation development and pharmacological evaluation. He is a consultant for organic farming of medicinal and aromatic plants in Andhra Pradesh, India. Now, I would request Professor Chandubabu Rao to introduce our eminent speaker for the session. Sir.
Good morning, all dignitaries and dear participants. This is Dr. Chandubabu Rao, Principal, Priyadarshini Institute of Pharmaceutical Education and Research, Guntur, Andhra Pradesh, India. Welcome you all for the today's AICTE sponsored International E-Conference on Pharmacy Practice and Therapeutics, organized by Nirmala College of Pharmacy, Mangalagiri, Andhra Pradesh, India, in association with Weizsäcker University, USA, and Myongji University, South Korea, on 19th and 20th August 2020. In this regard, I would like to appreciate and congratulate the management, Nirmala College of Pharmacy, particularly the Principal, Nirmala College of Pharmacy, Mangalagiri, Dr. Abdul Rahman Sir, for taking strenuous efforts and conducting this type of e-conferences and vast number of webinars and various online professional activities during this COVID pandemic session. I sincerely thank the management, that is patron, co-patrons, convener and other organizers of this international e-conference for giving me this wonderful opportunity to participate in this prestigious seminar and making me part of this prestigious event. It gives me great pleasure and great honor to introduce an eminent personality and speaker of this session to all of you, Dr. Van Wort. He received his PharmD from Weizsäcker University in Whitesbury, Pennsylvania, USA in 2003, and his PhD from the Medical University of South Carolina, Charleston, South Carolina, USA in the year 2008. For his PhD work, he studied the role of organic anion transporter 3, that is OAT3, in drug distribution and elimination. He currently has 882 citations and over 20 peer-reviewed publications. Dr. Van Wort, presently working as an associate professor at Weizsäcker University, he teaches toxicology, anatomy and physiology, receptor dose response theory, pharmacokinetics, pharmacology of the cardiovascular system, gastrointestinal system, infectious diseases and joint disorders. He is currently interested in oxalate transporters in relation to nephrolithiasis, that is kidney stone disorders. His personal interests include home improvement, cooking, investing in stocks and being self-sufficient. With this great introduction, I would like to invite Dr. Van Wort to give a presentation on the topic entitled Oxalate Homeostasis, Kidney Stones and our research on oxalate transport. Welcome you, sir, and thank you one and all for giving me this wonderful opportunity.
Hi everyone, my name is Dr. Adam Van Wort. I am an associate professor at Wilkes University's Nesbitt School of Pharmacy in the Department of Pharmaceutical Sciences. I actually work right next to Dr. Ajay Bamardi, who was one of the previous speakers recently. And first I'd like to thank Dr. Bamardi for introducing me to Dr. Rahman through email and the international webinar at the Nirmala, I hope I pronounced it correctly, the Nirmala College of Pharmacy. I really don't get to do many of these, especially international webinars, so I really appreciate the opportunity to do that. I am working from home, so, as a lot of us are in this day and age with this virus. So I decided, rather than show you my wall, I decided to have the theme of the global theme, because it's an international webinar. So I used that instead. So you're going to see a little bit, at least for this introduction, the background's going to be kind of cutting off a little bit here and there, but I apologize for that. Cutting off the headphones and things like that. But again, I really appreciate being invited for this. I was originally going to talk about our most recent publication, but I thought that was even a little too specialized to be of broad interest. And even the one that I ended up presenting on, which is about oxalate, homeostasis, kidney stones, and research on oxalate transport, that's what you'll be seeing today. That is a little less of a specialty, but it's hopefully not too focused, that you can all understand it to some extent. My background is, well, first I got my PharmD from Wilkes University, where I am now actually. That was in 2003. And then I got my PhD at the Medical University of South Carolina in Charleston, South Carolina. So obviously both in the US, but Charleston is much further south, both on the East Coast. So then after I got my PhD, I immediately went right back to academia. It's very similar, I think, to Dr. Bomarty. I think I've always had a passion for teaching. I really enjoy communicating knowledge in the best way that I can, and trying to simplify it as much as possible. Now, this is a research presentation, so it's still going to be parts of it might be a little harder to digest. You have to be a little familiar with the anatomy of the body, because it is on kidney stones, and a little familiar with some of the transporter studies that are done out there. So hopefully, though, you can grasp at least something meaningful from it. Again, I don't want to spend any more time on the intro. So again, I want to thank everybody for inviting me, and I hope you get something out of the presentation. Thank you.
Today I'll be presenting on oxalate homeostasis, kidney stones, and our research on oxalate transport. Now, my background is in renal transporters, renal organic anion transporters that normally handle drugs and toxins. So just a few years ago, I branched out and decided to study this endogenous anion called oxalate, which is very prominent problem or very prominent cause of nephrolithiasis or kidney stones. So we're going to start off with just an introduction, as we typically would, and then get into some of the pathogenesis, and basically the whole beginning is going to be describing more about oxalate, where it comes from, why is it a problem, just a little bit on current treatment, just a tiny bit, and then I'm going to get into my research, trying to address one of the questions, which is related to one of the transporters in the large intestine related to oxalate transport. So calcium oxalate nephrolithiasis has actually been increasing in the United States and really worldwide. We do have an international audience today, but a lot of the focus of this presentation was originally for United States statistics. But kidney stones are a nationwide or a worldwide problem. Okay, has a recurrence rate of about 50% in 10 years. Calcium oxalate is the crystal type found in up to 80% of cases. Okay, so a very large percent of cases of kidney stones are from the calcium oxalate. We have many other types of kidney stones, but this is the most common type. This is something that probably most people are probably not aware of, but bariatric surgery, which is the weight loss surgery, is causing actually more hyperoxaluria, which means high oxalate in the urine. It's kind of a complicated mechanism, but they've shown that if you have specific types of weight loss surgery, that will affect your fatty acid absorption, and that will affect your ability to bind to calcium, which then affects your ability to absorb oxalate. So it's kind of a complicated story, but there is a relationship between that weight loss surgery and then a higher incidence of oxalate in the body, just to keep that as simple as possible. Persistent nephrolithiasis can lead to renal failure and severe pain. Obviously, pain is one of the biggest issues. If you've ever known someone with a kidney stone, and unfortunately I've never had one, but the pain is generally described as really excruciating and one of the worst pains that someone has felt. And on the bottom you can see, so where did the word nephrolithiasis come from? And I won't go ahead and read that, but you can see, as many words are, its origin is in the Greek language. So oxalate is a terminal metabolite in mammals, and that generally, well, that means that oxalate is not further broken down, right? So that's the final metabolite. So the body either retains oxalate or excretes it, but it doesn't really metabolize it. It comes from the diet, and that's approximately 50%, depending on the specific person's diet, in hepatic and red blood cell production. Now, dietary hyperoxalemia is something we have some control over, but something called primary hyperoxalemia is caused by excessive hepatic production and some red blood cell production. Primary hyperoxalemia doesn't have a good treatment at this point. There's at least one company working on a treatment. And primary hyperoxalemia is generally much more profound, a much higher oxalate concentration. And you see that at birth, right, because genetic. Kidneys are the primary means of excretion of oxalate. Just about any endogenous chemical, the question is always raised, what is its normal role? I mean, this is something that's up for debate, but we know that oxalate drives chloride uptake from the lumen of the nephron by the SLC26A6 transporter. So maybe oxalate is there in blood to help facilitate chloride absorption. But in terms of its, does it have a critical role? Is it essential? Probably not. Okay, so it's probably at this point a better goal to just get rid of it rather than to try to retain some. Now, rodents appear to upregulate fecal oxalate excretion if hyperoxalemia occurs, but humans don't appear to have this ability. So that's going to be important to understand that rodents have some protective mechanism there. If there's too much oxalate in the blood, they can get rid of it. Humans don't have that mechanism. And at the very end of this presentation, I'm going to talk about a strategy that we're considering in the lab to hopefully kind of stimulate that same mechanism in humans to get rid of oxalate. In terms of treatments right now, again, not a lot out there. So this would be a treatment. The first bullet, there's a treatment for a stone that already exists. So that's extracorporeal shock wave lithotripsy. And that would be actually focusing sound waves from the external of the body or outside of the body, focusing sound waves on where the stone is approximately and breaking that stone apart. Okay, and that can be effective for removing stones lodged in tubules. It's not 100% effective, and it's not, not the most comfortable procedure. There's no absolutely effective or 100% effective prevention strategy for oxalate stones. There are some things that can be done. You can give a patient potassium citrate, because the citrate binds to the calcium in the blood, which prevents the calcium from crystallizing with oxalate. You can give a lot of fluids, which is not necessarily comfortable for the patient, but it is one mechanism to prevent oxalate stones from forming. Men have a higher incidence than women for one reason or another, but that has been changing recently. The female incidence of stones is going up a little quicker than men at this point. In terms of the rate of the rise in that incidence. So the major predisposing factors for kidney stones, particularly oxalate stones, but really all kidney stones, is the urine chemistry. So low pH promotes kidney stones. High calcium content. The calcium concentration is going to be really, really important, equally as important as the oxalate concentration. Randall's plaques, most crystals are not simple in that they might have other elements in them than the major element that's in the crystal. So Randall's plaques are calcium phosphate crystals that are generally thought to occur first in many cases. Those calcium phosphate crystals are kind of like the initiating event, and then those grow, and then the calcium oxalate can bind to that and grow off of this Randall's plaque. And a lot of folks may not be aware of this, but there's a poor crystallization inhibiting system in some patients. And that's still a really active area of research. And believe it or not, there are proteins produced by the kidney, or at least present in the kidney, that can inhibit calcium oxalate crystal formation and other crystal formation. So one of them would be TAM horsefall protein, or THF. That TAM horsefall protein does bind to like microcrystals, they believe, to prevent further growth of those crystals. So it's kind of preventing growth of crystals, not necessarily completely preventing the formation, but limiting the size. So that's an area of research that I'm not involved in currently, but it's something very interesting, potentially upregulating one of those inhibitory proteins. In terms of homeostasis, in healthy humans, serum oxalate is about 1 to 5 micromolar, but the urine oxalate is up to 500 micromolar. So as you can see, there's a much higher risk of crystallization in the urine. We don't really see crystallization in the blood. The serum oxalate concentration is usually normal, or often normal, in patients with idiopathic calcium oxalate nephrolithiasis. That just means that there are patients out there that still get calcium oxalate stones, but they have a normal oxalate concentration in the blood. Okay, then there's the opposite. There's several patients, several patients that have a very high calcium oxalate concentration, and of course they have a high risk of calcium oxalate stone formation. So the blood concentration doesn't have to be high to get these stones. Oxalate is produced in erythrocytes and in the liver, and also comes from foods, as I kind of alluded to earlier. So just one slide on erythrocytes. There's actually not a lot known about this, but there's a little bit of information out there in literature. Like the liver, the red blood cells produce oxalate from glyoxylate, or glyoxylic acid. At this point, we don't know what percent of oxalate is actually coming from red blood cell production compared to the liver production. But just to give you an idea, and this is the first time I think I'm showing the actual structure of oxalate. As I said, it's a very simple organic anion. It's just 2 carboxylic acids, right? Just 2 carbons. It's very simple. But LDH is one of the important enzymes here, or lactate dehydrogenase. And believe it or not, there is a drug company looking at inhibiting that to block oxalate production both in the liver and in the red blood cells. Now, whether or not that's going to have a lot of side effects, I guess that remains to be seen. So in the liver, it's a little bit more involved. Oxalate, as you can see down the bottom here, is produced in this multi-step pathway. It could start off with hydroxyproline, or start off with, again, glycolic acid. Okay, and what I have here in kind of orange or brown would be I'm going to call them the bad enzymes, because these enzymes promote movement towards the final step, which is the oxalate production. So that would be, I actually can't remember I think it's glyoxylate, might be glyoxylate synthase, and I think that's what it is, but I don't have the name here. And then lactate dehydrogenase. And then I don't have the names of all these, but if anyone is interested, they could feel free to kind of get reach out and get in touch with me. But these other enzymes are there in the liver, and these enzymes promote kind of the opposite. So the more DH is pushing you back to glycolic acid, the more AGT is pushing you from glyoxylic acid to glycine, okay, and away from oxalate. So the only point of this slide is to show you that there are potential targets here, drug targets, either upregulating these ones in kind of blue with the red outline, or maybe downregulating these ones in orange, potentially to reduce the oxalate synthesis. And that's, again, it's an active area of. Okay, now I want to start talking a little bit about the intestinal oxalate homeostasis. Oxalate is actually found in many seeds and leaves, and it's much more than that. I mean, the number of foods that have oxalate in them are very, very overwhelming. So here I just have cacao, spinach, tea. Rhubarb is another plant with oxalate. Almonds have a high oxalate concentration. In fact, most nuts have oxalate at all different, varying levels depending on the nut, and almonds are one of the highest. So, I'm not going to go over an exhaustive list, but there's a very large number of foods that contain oxalate. So about, again, 45 to 50% of oxalate that comes out the urine is actually starting from the diet, and of course that's modifiable. In the early small intestine, they believe oxalate may be absorbed paracellularly. That means between cells, maybe between the junction between the cells. In the small intestine and colon, oxalate was thought to be absorbed from the lumen by a transporter. And SLC stands for sol eukaryote, and that's the common kind of nomenclature for these transporters. But SLC 26A3 was thought to be potentially an important transporter for absorbing oxalate, moving it from the GI tract, and specifically in the colon lumen, then into the epithelial cells and into the blood. And at the end, not really at the end, but the second half of this presentation, I'm going to talk about our research on that transporter, and that's actually coming up pretty soon. In contrast, another transporter also in the GI tract is SLC 26A6. Just to warn you, they're very similar in name, but they do have different roles. And A3 is mostly localized into the colon. A6 is more ubiquitous. It's actually in most of the body, but there's a large amount in the small intestine, and that moves oxalate the opposite way. It moves it from basically from the blood into the lumen, right? So it's actually getting it out of the blood. So SLC 26A6, with respect to kidney stones, might be a good guy. If we could upregulate that one, that might be a good thing. Now, a little bit more on intestinal oxalate homeostasis. Only free oxalate is absorbed. This is going to be really important for especially any clinician that's treating patients to understand that if you can trap the oxalate before it gets in the blood, so that means while it's still in the GI tract, there's a chance of preventing that high oxalate in the blood. So Ray, if you just trap it there, then it'll be excreted through the feces. So you can use calcium, you could use magnesium, or really any divalent cation in the gut. As soon as they bind to oxalate, that prevents absorption. They crystallize very quickly or precipitate very quickly. Now, so some sources out there would recommend, and you might even find natural supplements or some products out there on the market on Amazon, for instance, or some other website where they're selling products with, in the end, they might just have calcium, and it might be, reported to prevent oxalate absorption. And that might be true depending on the timing. If you time it correctly, we know that you can block oxalate absorption with calcium, like calcium chloride or magnesium chloride. So you can try that. There's only one problem with this solution. Excess calcium in the diet can get into the blood as well, and that could promote other crystals, promote their formation. So having excess calcium in the diet does have risks associated with it. And it also, at least to our current knowledge, excess calcium in the diet probably will not affect or help with primary hyperoxalemia because that oxalate is already in the blood. Okay, so that's basically just that kind of in a nutshell to summarize that point. So next slide. Intestinal oxalate homeostasis again. So we've had a couple slides on this. So I'll be wrapping this up in a couple of minutes. So this is what I was alluding to a little while ago. So what are the transporters involved? So if you look on the right here, let me use a laser pointer. Hopefully you see that in green there. You look over here, there's the intestinal tract, which is A, and B is the systemic circulation or the bloodstream. So as oxalate is traveling, and that's OX2 minus here, oxalate is traveling down. There's some belief or some indications in literature that this A3 will absorb it right, from the GI tract, particularly the colon, into the blood. And there's some, and actually it's much stronger evidence that A6 pushes it out from the blood into the GI tract. Okay, so there's this dynamic here. Oxalate can go in the blood, it can come out of the blood. So there's this homeostasis in the actual intestine there. And one of the things that might be a good therapeutic strategy would be to upregulate this one that's secreting it. And again, that would be A6, which is secreting it into the GI tract, or potentially inhibiting A3. And we tried that, and that's what I'm going to talk about at the end here when I talk about the research that we've been doing on that. And there's one more thing to add here. This down the bottom in the intestinal tract, this oxalate being converted into CO2 and formate, that is done by a microbe. One of the common ones is Oxalobacter femiginese. I'm just going to talk briefly about that. Again, that's a microorganism that is known to consume oxalate. And they've shown that patients who have more of that microorganism are protected from, to some extent, not 100%, but protected to some extent from kidney stones based on calcium oxalate. So again, just briefly on Oxalobacter femiginese, it does consume oxalate for energy. It's found in the feces of 60 to 80% of adults, and you generally won't find it until 6 to 8 years of age. What that obviously means is it's not acquired during delivery. It must be acquired in the environment or through foods later on in life. Okay, but that's actually really directly related again to your kidney stone risk. There are a few studies out there where they've administered this orally as for instance like a probiotic. They've administered Oxalobacter femiginese, or they've administered an enzyme from the organism, a purified enzyme. And in every one of those cases, they show some effectiveness, and particularly in the case where they actually administered the entire bacterium, the Oxalobacter bacterium, they found that it helped, but it didn't harbor, the intestines didn't harbor it for very long. And that means it didn't survive in the intestines for a very long time. And I don't remember if it was a few weeks or a few months. But then when the patients lost it, there was evidence that, basically that they wouldn't be able to have that benefit anymore at that point when they lost the organism. There's a little bit of detail here, but it's just showing how the oxalate is metabolized by Oxalobacter femiginese. But so my colleagues and I have been studying other enzymes as well, even ones that haven't really been identified yet. But we found through a blast search online, there are some other enzymes or putative enzymes that are related to this Oxaloae decarboxylase. There are many other ones: oxalate decarboxylase, oxalate oxidase. There are several different oxalate degrading enzymes, but the one in this organism is the Oxaloae decarboxylase. It actually depends on another enzyme called formal-CoA transferase, but it has a transporter actually that brings an oxalate, and then again this is just a bacterium. It brings an oxalate in exchange for formate, and that does produce a proton gradient that gives energy to the organism. And it also digests the oxalate, as you can see here, to produce CO2 as basically CO2 and formate are really the metabolites. So you see formate up here and CO2 down here. So it actually uses that metabolite, formate, to drive the same transporter, right, to bring in more oxalate. So it's kind of feeding itself in that process. So so you could probably kind of realize already that there are many areas of potential research related to oxalate stones, and it could be probiotics, it could be research in the kidney, crystallization inhibitor proteins, it could be the transporters in the small intestine or large intestine. So many areas of interest for oxalate stones. I'm going to talk briefly about the renal oxalate handling, but I'll just tell you that this is not an area that I'm investigating in the lab. And the primary reason is because there are so many transporters in the kidney that have been shown to handle oxalate. And the chances of being able to kind of like to basically be able to target one of those without interfering with the function of the other ones, is basically going to be slim. And the main point is that renal handling of oxalate in terms of the transporters is very complicated. So what we decided to do in our research, at least to start, is to just focus on the intestinal oxalate transport. But I'll just show you just briefly, so what actually happens in the kidney. Like I said, the majority of oxalate is removed via urine. Oxalate is freely filtered, and now if you don't know renal anatomy, this is going to be a little more difficult. But oxalate is filtered by the glomerulus, which is, right, it's a passive sieve in a sense that has pores in it. And the oxalate is not bound to plasma protein, so that means all the oxalate in the blood can easily be filtered, or whatever amount of that fluid in the blood that is filtered, oxalate will go with it, right? It'll travel with it into the tubule, right? So this would be the lumen or the tubular lumen here, and this would be the interstitium, which is the other side. So what this represents here, this cell, is just a single epithelial cell in the proximal tubule, which is the beginning of the nephron, and right, there's 1 million of them in each kidney. So this is, obviously going to be, just one little cell, single cell model, but you're going to have many of these, obviously many copies of these transporters, probably millions or billions of copies of these transporters doing their thing at the same time in each nephron. So, I already mentioned SLC26A6 in the that would be in the small intestine, but I also mentioned that SLC26A6 is almost ubiquitous. So it is found in almost all cell types in the body, and again, the kidney is another one of those cell types. So if you look up at the top of this image, we have A6 here, A6 here, A6 here, and they're just showing you, and these are not different A6s, just showing you all the different things that A6 can do. So it can, bring chloride in this side, pump oxalate out, or vice versa. It could be oxalate pump in, pumping out sulfate, etc., etc. So it's it's a very complicated process in the kidney, and that's why whatever we end up doing in terms of drug therapy, because that's one of our goals is drug therapy. Whatever we end up doing, we want to try to avoid targeting tissues like this that we're not trying to target. The reason why I mention that is because we're actually starting to consider using gene therapy. Okay, so moving on. So how does a stone form? I already kind of alluded to this, so I'll just briefly go over it. So stone forms by starting off with something called a Randall's plaque. A Randall's plaque is a calcium phosphate precipitate or deposition on the basement membrane, and this is the loop of Henle. Okay, and that's just one nephron out of approximately 1 million. But that's right in the middle there. The loop of Henle is where we get calcium phosphate. And then collagen will adhere. Actually, this will adhere to the collagen, and then calcium oxalate will adhere to that. So the main point is that the calcium oxalate will latch onto or bind to this calcium phosphate or Randall's plaque. So if we could prevent Randall's plaques from forming, there's a chance we could prevent kidney stones completely. Right? So that's another area of investigation. So this might not be common knowledge, but the calcium oxalate stones, they don't start off where the urine is, right, in the lumen. They start off outside. That's the interstitium, the medullary interstitium, which is deeper in the kidney. Start off there, and then they will grow, and eventually they can block the tubule. And of course, they have to get into the tubule to get into the bladder or to get into the ureter, right? So they don't really start there, but they end up there at some point. So the main causes of kidney stones or oxalate kidney stones, of course, would be excessive oxalate production because of this primary hyperoxalemia. That's because of a genetic mutation. Excessive dietary intake of oxalate, or excessive intestinal oxalate absorption. And of course, that third one is probably more genetic based. To get more absorption, who knows, you might have more transporters there, or less, more absorptive transporters or less secreting transporters or secretory transporters. And there's a lot of evidence indicating that the calcium concentration in the urine and in the blood, but mostly in the urine, is as important as the oxalate concentration with respect to. So this is the final slide before I start actually talking about the data that we generated in our lab and our research. And it's just something I found interesting. I don't know how many of you are familiar with cystic fibrosis. You've probably heard of it, but it's not something that's commonly taught or extensive amount of time is not really put into that very much. So cystic fibrosis patients, they do have an increased risk of calcium oxalate nephrolithiasis. Now, cystic fibrosis, of course, where patients have very thick mucus in the lungs because their chloride transporter is not functioning correctly, and that's in the lungs. But that transporter, it's called CFTR, the cystic fibrosis transmembrane conductance regulator. CFTR is not only in the lungs, it's also in the pancreas, it's in the intestines. So it's in a lot of locations in the body, and that, because it is a mutation, it's going to be dysfunctional everywhere that it is normally expressed. And interestingly, so when I started this project, I didn't know that CFTR was related to anything that I was studying. And then when I dug a little bit in the literature, I found that CFTR, it works together. There's evidence that it works together with this one transporter, SLC26A6, that we're going to be working on pretty soon. We haven't started studying that transporter yet, but we're going to. But CFTR is actually like codependent, at least in the intestines. It works together with SLC26A6. Interestingly, the cystic fibrosis patients have a higher risk of calcium oxalate nephrolithiasis, right? So that's right up top here. So if they have a higher risk of calcium oxalate stones, and we know that their CFTR is mutated because that's what the disease is, it makes sense then that this SLC26A6 is codependent, or it has some relationship with CFTR. That means when they're both expressed, SLC26A6 actually works better when CFTR is next to it. And we already know that SLC26A6 is important for secreting oxalate from the blood into the GI tract, right? It's also in the kidney. So connecting all these dots tells us that probably the reason why cystic fibrosis patients, probably the reason why they have high calcium oxalate is related to a dysfunctional SLC26A6. And I don't know that that's been proven yet, but I found that very interesting, and hopefully, if I don't research it, hopefully someone else will be able to confirm that that's the reason why these patients have high oxalate. Okay, and that question was I kind of just addressed that question. So that's for a future thing. So what about what was our actual research that we already completed and published? So I'm going to talk about that now. Before I do that, I just want to remind you that there are two main transporters that I'm really focusing on in the GI tract, and that was the SLC26A3 and SLC26A6. The research I'm going to talk about now is just on A3, and it's an interesting story. We actually discovered that despite some of the literature reports saying that A3 was important for oxalate absorption, we found that it may not be as important as what the literature suggests. And I'm going to show you how we did that through kind of a lot of different steps to develop a specific cell line to help us figure that out. So again, the question was, what is the role of SLC26A3 in oxalate transport? And that's the human. We use the human form, and we used actually Chinese hamster ovary cells for all these experiments, and you'll see exactly how we did that in a few minutes. So the first step, and this is kind of my comfort zone. I mean, most of my scientific career was kind of involving cell lines, right? I've grown a lot of different types of cells. The most common cell line that I've used is the Chinese hamster ovary cells, which are probably the most common cells used, one of the most common cell types used for for experiments in drug companies or big pharma, depending on the purpose, but they're sometimes actually used to produce antigens, to produce antibodies. So it's a very common and easy cell line to work with, and that's the only reason why I used it, because it's very easy to manipulate genetically. So we expressed this is the human form, SLC26A3. Again, it's normally in the small intestine. We expressed that, though, in these Chinese hamster ovary cells, or CHO cells. But we did so in a different way. In many cases, investigators will express a protein constitutively. That means once you add the gene to the cells, it's expressed all the time. We decided to express it in an inducible manner. So that meant that we wanted to have that transporter not expressed, right, or turned off most of the time while we were growing the cells. And the reason why I did that very intentionally is because we thought that if they have an excess of this remember, it's a chloride transporter. SLC26A3 is, even though it's it's believed to be an oxalate transporter, its primary role is actually as a chloride transporter. So it does, to best of our knowledge, at least when we started these experiments, we thought that it did both. Okay, and it's well known as a chloride transporter. So basically, we wanted to minimize that potential detrimental effect. If we constitutively expressed it all the time, we thought that the excess chloride, maybe intake, would potentially be detrimental to cell growth. And it turns out that another group reported that is true, so we were kind of happy to see that. So this was my first venture into making an inducible cell line. First time I ever tried, first time our lab ever worked on this kind of thing. So we were happy because our first attempt was a success. So what we did is we actually used a system from Invitrogen called the Flip-In T-Rex. Okay, normally it's just Flip-In, but if you wanted to make it inducible, you use the T-Rex, which is the tetracycline inducible. So you buy the CHO cells. They already have a target in their genome that's ready to basically recombine or ready for you to add a foreign gene. And I worked with some colleagues to essentially make a plasmid that we can transfect into these cells that expresses the SLC26A3, but it also has the tetracycline inducible element. And I don't want to get into the details of that methodology because you could spend at least a half hour on that. But what we found, in our just preliminary experiment, was that when we gave, first of all, this is a Western blot on the very bottom. So we're running, it was probably 60 micrograms or so, but we're running protein from our plain CHO cells or control cells, our cells with no tetracycline, and then our cells with the recommended amount of tetracycline, or 5 times the recommended amount of tetracycline, and that was about, I believe, a 24-hour induction. And all this research that we're going to talk about now was published in this article on the bottom here, fairly recently. So we used basically an antibody to show that the colon, which the colon should have SLC26A3, the colon showed a very, very large band, but at least it was a positive band. We were happy that it was positive. The CHO cells that were not transfected showed nothing. The CHO cells with no tetracycline, but these were transfected with no tetracycline, showed nothing. So the main point is that this Western blot proved that we got the gene to be expressed, and it was not leaking. So there was no expression without the induction. So we're really happy to see that. And that's only part of the story, because the other part, or the other question, is where is it expressed? Because this is a membrane. It's supposed to be a membrane protein. It's supposed to be transporting, right? So it has to be in the plasma membrane. So we did immunofluorescence, and fortunately this worked the first time as well. When we did immunofluorescence for SLC26A3, we didn't have a tag, right? There's no flag tag. There was no GFP. We directly stained the SLC26A3 protein with a commercially available antibody. We got a much stronger signal on the perimeter of the cells. We also saw that some of the cells probably weren't as bright as the others. So that meant that potentially the expression was heterogeneous. So we actually ended up subcloning individual cells and finding the absolute strongest expressors. And what you see at the top right, the reason why that's blank is, I'll just tell you right up front, we didn't do a DAPI stain for DNA, which we should have. But if you look at the bottom here, this is the exact same set of cells with the same view, and you'll see that so none of this fluorescent stain showed up, so there was no fluorescence in these are the cells that were not induced at the top right. Uninduced, top left is induced. So we're really happy to see that this expression system is working, because that in and of itself can be a challenge in some cases. So now that we knew that that was working, the obvious question is, okay, so what is the function? Is it functioning as an oxalate transporter? So our first, or at least one of our first experiments, was to do a time course of oxalate uptake in the uninduced, which are the open or white squares, and then the induced SLC26A3 CHO cells. And this is a time course, right? So all it's showing us, at this point, it's just showing us, how long does accumulation take before it reaches steady state? And is there any difference between the regular or uninduced CHO cells versus the induced CHO cells? And we were a little disappointed to find that in this experiment, there was no obvious difference. We used radiolabeled oxalate, so the detection was very sensitive, it was very accurate, because we didn't use chromatography, which is a little more complicated. So we just used radiolabeled oxalate at 100 micromolar. We arbitrarily chose that concentration, just kind of as a simple concentration to use. But the main point is we found no difference, at least in the time course study. So despite some of the reports in the literature that this transporter actually did transport oxalate, so far we didn't see that that's the case. And we are using a simple cell line that's not the natural environment of this transporter. But believe it or not, these CHO cells are usually very good at showing function. With all the other transporters that I've studied, they usually do show function if that transporter is indeed a transporter of that substrate. So we thought this is not a really great sign, at least for that transporter. But we didn't give up at that point, because the Km, or the concentration at which this transporter is at 50% of its maximum rate, is pretty high. And that means it's not a very high affinity transporter for at least what's been reported in the literature. And what I'm basically getting at is that some investigators have already studied this, but they studied it in other species such as rabbit and mouse, and not the human transporter. So we wanted to see that, if the human transporter functioned similarly to these other species, and what we found was there may not be as much transport in the human SLC26A3 as there is maybe in some other species. Okay, and what we found is, if you go high enough, if you go to a high enough concentration, there's some evidence that there's going to be transport. So if you look at 2 millimolar, 2000 micromolar, we see a little bit, and that's statistically significant, significantly more transport than in the uninduced cells. Up to 5 millimolar, we saw a difference, but it wasn't statistically significant. But we had that trend. So that was showing us that the transporter might not actually be doing much until we reach a very high concentration of oxalate. So this evidence so far told us, well, actually, if you look at it, two things. There's not much transport, but something very strange, even kind of stranger than that. So if you look at the bottom curve, right, and I don't know how many of you are familiar with these transport experiments, because I've been doing them for many years. You look at the bottom curve, you see that it becomes saturated, right? As you raise, you raise the oxalate concentration. This is the transport rate, so it's picomoles per centimeter squared per 5 minutes. So it's actually the rate of transport. The rate becomes saturated. So if the CHO cells uninduced, if they don't have a transporter for oxalate, then if it's just diffusion, right? Normally diffusion is not saturable. We did not expect to see, and I've seen many other substrates and many other transporters, this should be aligned, it should be linear. In the control cells, there should be no saturation here, but we found saturation. And that told me that, oh man, did we pick, just by chance, did we pick a cell line that already had transport function? It has its own transporter for oxalate. And that was disappointing because it meant we couldn't conclusively say if this A3 was like a strong transporter or not when we had this confounding effect in the CHO cells endogenously. We didn't give up on that question, though. We moved just a little further, and we said, well, right, so if the CHO cells really do have their own transporter, even when we're not expressing one, right, apparently they have their own function. We said, can we at least figure out, is that inhibitable? Is it actually a carrier, or is it, right, because if it's diffusion, it shouldn't be saturable. So it has to be a carrier. So if it's a carrier, is there anything that would inhibit it? And what I said was, well, almost all of these chloride transporters that I know of can be inhibited by one specific chemical called niflumic acid or niflumate. Now, niflumate is an old NSAID, non-steroidal anti-inflammatory drug. I believe it may still be on the market, but it's probably not used, at least in this country, in the U.S., not used very often for inflammation. But it's something that's used scientifically as a tool to block chloride transporters. And I said, well, why don't we just try it just to see what happens in the control cells and in the induced cells. What does niflumate do? And we found that, believe it or not, in these uninduced cells, right, and we absolutely proved that there is no leaking expression. There is no SLC26A3 in these uninduced cells. So we said, so we basically found that niflumate still blocked that. So this would be, again, in 10 minutes, it was, again, it's actually quite a bit, 5 millimolar oxalate we gave for 10 minutes in the CHO cells. We found that if we gave the inhibitor niflumate, and it's only 200 micromolar, so it's a very potent inhibitor. And when I say very potent, I mean compared to the substrate concentration, which is 5,000 micromolar. The niflumate cut it down to less than half with no transporter. So that told us that there must be a transporter somewhere in these cells. And that remains, at this point, remains unknown. We've searched the literature quite a bit to find out, has anyone shown, is there a specific transporter in these CHO cells? Because they're so commonly used, it would be important to know that. But to our knowledge, no one has published that yet. We haven't figured it out yet. So what is the transporter that's doing this? There's got to be something. So just to be thorough, we said, well, yeah, we're gonna do the exact same thing right after the induction and see if there's any difference. Well, there may have been a subtle difference, but it wasn't statistically significant. So we showed niflumate did basically the same thing with or without the transporter that we added. So that's the hallmark sign that is a carrier-mediated process if it's being blocked by this transporter inhibitor, right? And it's saturable. So that leaves that question still up in the air about the CHO cells. So that left us with, kind of a choice. When we found that this transporter wasn't really doing much, we said, well, we can just stop there, right, and move on to another project, which we did, start another project, or we could also kind of investigate this further, right? So I think any scientist has to be a devil's advocate or their own devil's advocate. That means, you need to absolutely prove that what you are concluding is correct, right? You don't want someone else to disprove what you're saying. So you want to be 100% sure that what you're saying is accurate, right? So what we said was, well, what if being the devil's advocate, what if this transporter is in, we found, it's in the membrane, we did immunofluorescence in Western blot and we found it, but what if it's just not functioning correctly? What if something went wrong with the gene that we ordered, and we actually cloned it, we transferred it through multiple plasmids? What if something went wrong with the gene? So what we ended up doing was we said, okay, does this transporter have any of their functions that we can prove that are still working? And the answer is yes, and that is chloride. SLC26A3, before anyone even considered oxalate as a substrate, SLC26A3 was shown to be a chloride transporter, and in fact, one of the most common reasons for congenital chloride diarrhea is non-functioning SLC26A3. So patients that have a mutation in this gene, in this protein, a lot of them are born with severe diarrhea, and they're losing so much chloride. So it's first and foremost a chloride transporter. So we said, can we at least prove that it's still transporting chloride, even if we can't find oxalate transport? Right. So the reason, or the way we studied that, and this took a lot of planning, because I said, well, we already have one gene in the cells, right? We have the transporter gene. So I said, well, how are we going to measure chloride concentration? Could we just use a dye, right? They're chloride dyes, and there are chloride sensitive dyes. And I did a lot of reading on them, and it turns out that a lot of investigators argue against these chloride sensing dyes because they leak out of the cells. They're a lot more finicky to deal with, right? They're not stable, etc., etc. So we got a little crazy and we said, well, why don't we add another gene to the cells? Because I did a lot of digging through literature, and I found that there is a protein that is a chloride sensor and a pH sensor, and the name is clofensor. I'm going to call it clofensor. I don't know how the guy who basically discovered this, or who actually invented this, I don't know how he pronounces it, but I'm going to call it clofensor, and that's CLOPHENSOR. And that is basically, that's standing for chloride pH sensor, is the clofensor. So believe it or not, we took the cell line that we already engineered with the inducible transporter, and we added a constitutively expressed fluorescence sensor, and that's called clofensor. And the sole purpose was to prove that the transporter at least did what it was supposed to do, and that's transport chloride. So what is clofensor? I'll just briefly tell you so you can understand the experiments. What does clofensor actually do? This is a fusion, and this is something kind of that I've never had the opportunity to invent or the foresight to invent, and I wish I did, but this is a fusion protein between one type of GFP and a red fluorescent protein. And the way this fusion protein works is that on the left side in this picture, this fluorescence, now keep in mind this is fluorescence, so in every case you have to have an excitation wavelength, and then you have to measure at a different wavelength, which is the emission wavelength. So basically when you excite E2-GFP, you'll get you can get a cyan, which is this color in the middle here. It's like a blue, right? Obviously most of you probably know cyan is that color, same color that we put in our printers, right, in many cases. That cyan is going to respond to one thing, which is, I'm going to show you in the next slide, either chloride or pH, and then the green is going to respond to something else. So what I mean by that is we have a dual sensor of chloride and pH. Okay, in fact it's right up here. So the E2-GFP portion responds to chloride or pH depending on the wavelength used. The DS red M portion has a fluorescence intensity that does not change with pH, chloride, or other conditions. So the beauty of this is really cool, because that means that for every one of these, every single molecule of this protein that is produced, or every copy, we always have a red one, and we always have the GFP. So even if I have 1 million wells of cells, and every well has a different expression level, right, or different number of cells even, one well has half the cells, and I'm doing this experiment, it shouldn't matter because the ratio of the green to the red or the cyan to the red, and I'll show you what I mean by that, the ratio is all that matters. So it allows us to very kind of beautifully, without measuring the amount of cells or the amount of protein, we have this internal control so that the red fluorescent protein is always at the same abundance as the green fluorescent protein, and this intensity never changes on the right, whereas the green one will change and the cyan one will change based on chloride or pH. Okay, now it's getting a little complicated, but before I move on to the next slide, I just want to emphasize, or at least show you that, at least with respect to chloride, this is a negative response. So the more chloride you have, the less fluorescence you have. Okay, so it should suppress the fluorescence, and that should not affect the red. Okay, so what does this actually look like? And this is not my experiment. We did do this. I don't have the pictures. We didn't want to publish that because it's been done before. But this Daniel Orosio published this in Nature Methods, and I've actually emailed him to communicate just for troubleshooting. He's been very helpful with us, but what they've shown is that if you, again, this might be a neuronal cell line, I don't remember, this is a different cell line than what we're using, but when they use, when they change pH, the green fluorescence will go up according to pH. The cyan does not change, the red does not change. When they change chloride from low to high, both green fluorescence decreases and cyan decreases, but the red does not change. So this allows us to very nicely say, okay, if I want to have to generate a standard curve for measuring, for instance, measuring pH, I could measure the ratio between green and blue, right? The ratio of green to blue intensity could tell me the pH. The ratio of, let's see, if we look on over here, the ratio of cyan to red could tell me the chloride concentration. And it's a little complicated, and I'll show you how I did that. I think it'll be a lot easier to understand when I show you those images or those figures. But essentially, this is just one single fusion protein that's doing all this at the same time. Okay, and ultimately the purpose is to be able to measure the chloride concentration inside the cells and the pH inside the cells. The only thing that's really unique about what we did is we're the first that I'm aware of, the first to do it in a multi-cell format, so in whole wells rather than single cell. Okay, we did it in a complete full well format, so we can get well, because we had a plate reader, right? So use a plate reader rather than a microscope, but it's more automated, right? So what we found, first thing here was, and I'll just clarify, even though we did all of our final experiments in intact cells or whole cells, we standardized or calibrated the sensor in lysed cells because we had the ability to control pH in the chloride concentration in the lysate much easier than in whole cells. So we lysed the SLC26A3 CHO cells that also had clofensor, and we didn't even induce the transporter because we just wanted to prove that the sensor was going to work. So what we found is that as we raised the pH, we got a very obvious and consistent change in the ratio of the green to the cyan fluorescence. So let me go, well, I'm not going to go back because I'm recording this on PowerPoint and then it'll interfere with my recording. But if you go back in the video, you can see essentially that you can look at the cell diagrams or the cell figure and show that the green to cyan fluorescence is going to show us our pH. So the green would go up, whereas the cyan shouldn't really change, right? And that's going to give us this nice curve. So the first thing that this means is that, okay, this is only in cell lysate, but if this still functions the way it should in whole cells in a whole multi-well format, that means we can measure the intracellular pH in large batches of cells and get the average intracellular pH. So that's really neat, really cool. So we move on. That's the first step. What about the chloride concentration intracellularly? Well, if you look on the right here, this is only 3 experiments, but we did 9. We did 6 other pHs. But I wanted to show you for an example here. When we looked at the change in chloride, right, we changed the chloride, and this is on a log scale, the chloride concentration, we increased it. We found, and this is what's been shown in the literature before, again, that was with single cells, but we use cell lysate, right, which is different, a little bit different. But we showed that, just like has been found in the literature, the pH would change. Different pHs will give you a different affinity of chloride, or for chloride, for the sensor. So what that means is that this whole experiment was done at pH 6, but we changed the chloride concentration. We had different wells, different sets of wells. I think it was 3 for each. So as the chloride goes up, the cyan to red fluorescence goes down. As the as we raise the pH, and the bottom one is 7.5, this curve is going to change a little bit. It's actually going to change the affinity, and I'll show you on the next, I believe it's on the next slide, how that affinity changes. So why this is all important is because we cannot measure the chloride concentration until we first measure the pH, because the chloride signal is going to depend on the pH. So the chloride affinity depends on the pH. So we'll first use our pH sensor wavelengths, and then we used our chloride sensor to figure out the pH and the chloride. So what that boils down to is, if we look at both pH and then the chloride, right? We look at a bunch of curves. How does the pH affect the chloride affinity? Let's see that 1, 2, 3, 4, 5, 6. Yeah, so we have 9 of them. So those are those 9, and I showed you 3 out of the 9. Those 9 curves. How does the pH affect the affinity of chloride for clofensor? And this is the KD, or dissociation constant. So this shows us at a lower pH we have a lower KD, which means a higher affinity. So notice this is very nonlinear. So as we get up to a very high pH, we get a very low chloride affinity. So this is very critical, because without knowing this, without knowing the pH intracellularly, we might give a false chloride concentration. And what you're seeing here in the boxes is what's been reported in the literature for single cells. What we're reporting is in cell lysate. Okay, so we got a pretty similar result in terms of the affinity of chloride at different pHs. Okay, so now that we had a method for measuring the pH in the chloride, we went ahead and we said, well, now can we prove that the transporter is actually functioning, at least as a chloride transporter? And I have to warn you, this experiment is a little bit complicated to understand, because you have to understand a little bit about bicarbonate. What bicarbonate does to cells normally is kind of complicated. So let me just kind of explain that before we even get into the experiment. It's something I had to discover and read about after we did this experiment, because it was a little confusing. But it's well known that if you give bicarbonate extracellularly, but you have a buffer, right, buffering it at whatever pH you want, the more bicarbonate you give, believe it or not, the more you lower the pH inside the cell. Now, most of us think of bicarbonate as alkaline, but I'm saying that in a condition where bicarbonate is more abundant, but the pH is not being changed, right? You're buffering it. That bicarbonate can promote. To me, it's kind of a complicated mechanism, so I won't be able to get into it. But it promotes a lowering of the intracellular pH. So that's just to give you that kind of that information before we get started with the experiment, and we'll do that now. So on the left side, this experiment that we did again was in whole cells, whole CHO cells, not lysate. We wanted to know what happened to the intracellular pH when we did this this is like testing the transporter. So we incubated the cells in 130 millimolar chloride buffer. right? And that's just a normal amount of bicarbonate, whatever is normally in cell culture medium or transport buffer, but kind of a lower amount of bicarbonate. And this is, a fairly normal amount of extracellular chloride. We found even at the baseline, right? And again, these are on the black. The black on the bottom is induced, so the transporter is induced. On the top, there's no induction. Even at baseline, there was some difference between the cell types, and again, this is the pH. So we used that Clofensor sensor to calculate this pH, based on that ratiometric method. So using a plate reader. So we found that the pH was higher with no induction and lower with SLC26A3. We weren't sure exactly what to make of that first result, but what my whole goal was to say, well, what I wanted to figure out was if we soaked those cells in chloride, right, soaked them with that chloride, some of that should get inside the cells. And we know that, I know from the literature, this transporter is an exchanger. That means it should be able to exchange bicarbonate for chloride, and these exchangers in most cases work in both directions. So I said if we preload these cells with chloride and then we add high bicarbonate, we should be able to change that chloride. Okay, so the chloride is going to be on the part of the panel B, but I'm not going to get into that yet. But we're still looking at pH. So when we tried to force bicarbonate in and force chloride out, something strange happened. We noticed that in the uninduced cells, the pH dropped very significantly. Now, on the scale, now it is logarithmic, right, because it's pH, but it doesn't go down to 0, of course. So just make note of the scale when you're kind of judging this. But the pH went down significantly, statistically significantly went down. And that's why I told you about that phenomenon that occurs, because these are all buffered at the same pH, and I think it was 7.4, right, physiological pH. So the intracellular pH went down, which is what commonly occurs with bicarbonate if the bicarbonate doesn't get, significantly get absorbed into the cells or transported into the cells. What we found, though, is that when we induced the transporter, the cells were resistant to that pH change. In fact, they showed no pH change pretty much at all. And what that told me is that bicarbonate that in these control cells that was lingering outside was probably taken up inside the cells, so it didn't have that effect that would normally cause a lowering of the intracellular pH. Okay, so I think we to some extent we proved that at least the bicarbonate transport was happening, and it was different compared to the control cells. So that's a very good starting point, because this transporter is supposed to handle that bicarbonate in exchange for chloride. So what we did, in the second part of this experiment, which is probably a more important part, is we tried to prove that the chloride concentration inside the cells is going to change in the presence of the transporter. So the baseline, and unfortunately there was a little variability in this data, okay, and for one reason or another, we weren't sure why, but the baseline chloride was higher in the induced cells, right, in the transporting cells with the SLC26A3. So that was a good sign, even though it wasn't statistically significant. It was a good sign because that was a higher chloride and a lower bicarbonate, and the cells that have the transporter should be able to take up more chloride, and they did. And we did this exact same thing that we did on this side. We basically, and I should have clarified, we dropped the chloride completely out of the extracellular fluid. So we removed all the chloride, and then we added high bicarbonate. And the whole purpose was, again, to fuel that transporter, to force bicarbonate in and pull chloride out. And we were really happy to see that only in the induced cells was the chloride able to drop significantly intracellularly. So this is the intracellular chloride. So what that ended up proving is that, our observation that SLC26A3 is not a very strong oxalate transporter is probably a correct observation, because we've proven that the transporter that we were working with, that we induced, is still functioning as a chloride transporter. It's just not transporting oxalate. So it's in the membrane and it's doing its normal job, right? But again, some of those literature reports in mouse and in rabbit that showed that this transporter might be important because there's a knockout model of SLC26A3. Well, we're showing, I would say that this is just one study and one publication that I showed you. We're showing that it's probably not that important in humans as like a primary mechanism for absorbing oxalate from the GI tract, particularly the colon. Doesn't mean it does nothing. It means it's probably not a primary mechanism for absorbing it. So we're going to wrap things up here. We're at the take-home points. So calcium oxalate nephrolithiasis is still a problem in the world. About half of oxalate is from the diet, about half is from endogenous production. There are strategies to prevent stone formation. Several strategies to prevent stone formation can be theoretically beneficial or helpful in the future. One possible strategy is to prevent oxalate absorption from the intestines. Something that has not been heavily investigated, which is more exciting to me, is to force or promote oxalate secretion from the blood into the GI tract, and that's the only mechanism, at least in the GI tract, that would help oxalate that's already in the blood, help get rid of that oxalate. Modification of hepatic glyoxylate metabolism. Like I said, there's a drug company looking to that now. Destruction of oxalate via bacteria or recombinant enzymes. Now, destruction of oxalate in the gut is going to have some benefit, and they've already shown that. It may not have a major benefit with primary hyperoxalemia. So if someone can invent an enzyme that breaks down blood oxalate and the enzyme functions in the blood, that's probably going to be great, like probably one of the best inventions. Again, blocking its synthesis would be great if we could avoid any side effects of blocking those important enzymes in the body. What we've proven with our research is that SLC26A3 may not be a useful drug target, at least for preventing oxalate absorption. And I haven't gone into the literature in this presentation, but SLC26A6 has been shown by many labs to be important, like I said, for oxalate secretion. So if we can upregulate A6 in the small intestine, and maybe in other parts of the GI tract, such as the colon, there's a chance that we can promote removal of oxalate from the blood. And they've already shown that in knockout mice, where they deleted A6, they had a higher risk of hyperoxalemia, higher risk of stone formation. So the opposite hopefully would hold true, that if we if we upregulate it, maybe we can prevent crystal formation. Okay, and that's kind of a summary here. So why would we upregulate A6? It's already proven as a secretory transporter. It might, like I said, it might treat primary hyperoxalemia, not just dietary derived oxalate. And it may actually help to prevent oxalate absorption, because as soon as the oxalate that's in the diet gets into the luminal cells in the GI tract, there's a chance that this transporter can force it right back out. So it may be able to handle oxalate coming from multiple sources. So how would we upregulate this in vivo? So if you haven't figured it out yet, this is one of our future goals, right? Is affecting, particularly stimulating SLC26A6 in vivo. One way would be to look for a transcription factor that we can upregulate, hopefully through a hormone or a small molecule, might be easiest, or gene therapy, or use gene therapy to directly upregulate the transporter, rather than going through a transcription factor made to directly target the transporter and increase its expression. And I've been looking at adeno-associated virus recently, but haven't had much time to learn. There's probably going to be some surgery involved to target that, perhaps the mesenteric artery injection. The first step would be, again, identifying those transcription factors, which we haven't really done much of yet. We're just starting to work on that. I'm combing the literature for potential transcription factors, and then determining the best approach for gene targeting to the small intestine. Some groups have used They've tried, let's see, the injection of adeno-associated virus directly into the small intestinal lumen. The same group tried giving adeno-associated virus in the superior mesenteric artery, and they showed that that actually was better at getting a higher expression level in the small intestine. So there are a lot of questions out there and a lot of different approaches that can be taken, but we're going to try to find kind of the best approach to possibly upregulate this. And if you could do it only in the intestine, that would be better than doing it throughout the whole body, right? Because it is throughout the whole body, this transporter. So that concludes my presentation, and now I'd just like to acknowledge just a few people in Wilkes University. First of all, Dr. Abdul Rahman, I'd like to thank you for allowing me to participate in this symposium. It's really an honor to be involved in an international symposium, which I haven't really done before. So I really appreciate that involvement and request. And Dr. Ajay Bamari, my friend and colleague at Wilkes University, for bringing this to my attention in really connecting me with Dr. Rahman to allow me to participate in the symposium. And Wilkes University, really for offering me the resources. They've offered many resources financially and with allowing me to have time to work with students in the lab to accomplish some of these things, and I really appreciate that as well. And lastly, I'd like to thank everyone for listening to my presentation, and please feel free to reach out to me if you have any questions or interest in any kind of collaboration. Thank you and have a good day.
Thank you, Dr. Adam Van Wort, for such a nice and beautiful presentation. I'm sure your in-depth analysis of the topic is definitely going to address the concerns and queries of the delegates related to kidney stones, their types, mechanism of their formation. We have shortlisted a few queries from the participants and would request you to address their queries. A list of queries are displayed on the screen for you to take them one by one. Sir.
Okay, so time for some follow-up questions. First, I'd like to say I think these questions are really excellent questions, and I'd like to thank everyone who listened for really coming up with these excellent ideas. So I'm going to go ahead, I put them all on the same slide. I'm going to go ahead and address them one at a time. The first question was whether the presence of uric acid aids will oxalate production in the body. And I think the purpose of the question was, at least my best understanding is that does uric acid promote oxalate production in the body? And the first thing I wanted to point out in answering that question is just the structures here. If you look on the left, that is uric acid. Okay. If you look on the right, that is oxalate with these delocalized bonds. Okay, oxalate structurally is very, very different from uric acid. And there's no evidence that I'm aware of to indicate that oxalate can be produced from uric acid. But the remaining question, I guess, is whether or not just the presence of uric acid, excess uric acid, can promote oxalate, calcium oxalate crystallization. And I have to be honest, I had to read and look up a lot of these because these questions are not questions I think about all the time. And this one I had to read about, and I found a really good journal article. It's an older one. It's 1984 in the journal Urological Research. It is by and I don't know the first name, but the scientist is Tiselius. Again, that's 1984 Urological Research, and they actually studied this very thoroughly in vitro. What is the effect of uric acid and the effect of monosodium urate? Because sodium or monosodium urate is what is causing gout. That's the main crystal form in gout. But uric acid on its own can crystallize. So they tested both of those, and they found there was next to no effect, even with a very high concentration of uric acid or monosodium urate, there was next to no effect on the likelihood of calcium oxalate precipitating. So I guess the answer to that question is not likely a direct effect. Now I want to emphasize though that if you see in some patients that both of those crystals might be more likely together, that might be because of some secondary reasons. It might be because of dehydration. It might be because of, again, the pH. And to be honest, though, the pH appears to be a lot more relevant for uric acid or monosodium urate crystals forming. And as you might know, uric acid is very insoluble at acidic pHs, so it's much more susceptible to pH-dependent crystallization. And that leads me to the next question, which is calcium oxalate. The question is, calcium oxalate develops in acidic urine, pH less than 6. Calcium phosphate develops in alkaline urine, pH greater than 7.5. Finally, maintaining the pH around 7 would help in avoiding both of the above-mentioned type of stones. What is your view about it? And that's a really good question that I'm going to try my best to address. Okay, so from my understanding and my reading, what I found is that the likelihood of calcium oxalate crystal formation at different pHs is really, regardless of the pH, the likelihood of calcium oxalate crystallizing is still pretty high. And what I mean by that is it's much more related to the concentration of calcium and oxalate than it is to the pH. Now, if you could shoot really, really high at a very, very alkaline pH, there's evidence that you can dissolve calcium oxalate crystals. It's generally pH you won't find often in the urine, or that would be harder to achieve, probably higher than pH 8. Whereas below that, in the normal range, and as you mentioned, pH 6 is pretty common in urine. That, up and down, moving the pH up and down in that range is not going to have a really strong effect on the likelihood of calcium oxalate crystal formation. The opposite, though, if we're talking about uric acid stones or monosodium urate stones, it's very, very related, highly related to pH. And of course, the lower the pH, the higher the risk of a uric acid stone or monosodium urate stone. And I did find an article somewhat related to this, and that was in Kidney International in 2004, Association of Urinary pH with Body Weight and Nephrolithiasis by Dr. Malouf. Malouf was the first author, last author P.A.K. Charles. And what they found was that, and this actually addressed question 3 to some extent. What they found was that obese patients, the higher their weights, the higher your weight, the lower the urinary pH. So there's actually, and this is new to me, to be honest. Reading this is really interesting. So the higher your body weight, especially if you're in the obese range, the lower the urinary pH. And the biggest concern that they addressed in the article was the risk of uric acid stone formation, not oxalate stone formation as much. It doesn't, and I'm not trying to say that oxalate has no dependence on pH, but it's not nearly as important as the concentration of the oxalate in the calcium compared to uric acid, whereas uric acid is highly dependent on pH. So again, let's kind of formally get into that question 3. That was cystic fibrosis patients are at an increased risk of calcium oxalate crystals in the medullary region of the kidney. Do you think patients suffering from gout, obesity, and diabetic ketoacidosis are also under increased risk of developing calcium oxalate stones in kidneys? What I found is that there is a risk of obesity. Obesity can cause it does cause an increased risk of calcium oxalate stones. Okay, they don't believe that's directly related to the pH of the urine, but they believe, maybe to some extent, but they believe it's related to a lot of secondary things that are happening. They've shown changes in citrate concentration in obesity, perhaps a lower free citrate concentration that would make it more difficult to bind to and sequester that calcium in the urine. So there are a lot of secondary things that they found in obesity that do promote. Yes, so the answer is that there's an increased risk of calcium oxalate stone formation. And even in diabetes, they have found that there is some increased risk as well. and in fact, there was a study that showed there was actually an increased oxalic acid concentration or oxalate concentration in the blood in obese patients. So the exact reason why we may not know. There could be a lot of potential reasons. It could be related to their diet. Yeah, as I think I might have alluded to this briefly in my presentation, but more fatty acids present in the GI tract. There's evidence that those will bind to the calcium there in your diet, and that frees up the oxalate to be absorbed. So that's just a guess on for my own kind of thought process. That's the guess that I came up with, but there is evidence that oxalate can be elevated in obesity. And as I mentioned more specifically in the lecture, that bariatric surgery can lead to hyperoxalemia in many cases. So it's surgery for being overweight or obese. Next question was, do you think the use of probiotics containing microorganisms non-native to the human gut flora would affect the existing habitat of friendly microorganisms in our gut? I love these kinds of questions, actually. I think it's an excellent and really important question because the more years that go by, the more we learn that the gut flora are probably a lot more important than we ever realized before. And some people think gut flora are related to your mood. Some people think they're related to your risk of obesity. There's so many things that they're beginning to connect to the gut flora that nobody knows the answer to that. I guess at this point, if we administered a non-native flora, even if it's native for other patients or other humans, if it were Oxalobacter femiginese, if we can get that to persist and stay for months or years, would that cause other problems? I guess my answer is almost anything you change in the body can cause other problems, right? So we'd have to figure out what that is, and it's always the risks versus benefits. The benefit of lowering oxalate, if that works well in that system with that treatment, it might be greater than the risk of whatever else might be happening with your normal flora. So it's a really good question, though, that I'd like to see the answer to at some point. Next one is whether change in hormonal concentration due to use of anabolic steroids also result in formation of calcium oxalate stones in kidneys, as it is observed in the case of bodybuilders who frequently suffer from kidney-related ailments. I want to start off at the end there. First of all, that is true. It's a fact that some bodybuilders can get acute kidney injury, acute kidney failure, and what they found in a lot of those bodybuilders that get that, usually they're on anabolic steroids. Usually they're on a lot of supplements that are in a normal person they wouldn't normally be taking. They're not necessarily required. And I think this is complex because the bodybuilders in many cases are overloaded with supplements, and it could be nutrients, it could be vitamins. In some cases it's based on evidence that'll help them build muscle mass. In other cases it's based on something that they read in a magazine that has no scientific evidence behind it. But sometimes these bodybuilders will have so many solutes in their urine that any crystal is more likely to form because they're super saturating the urine with vitamins and minerals and things like that. However, there is evidence, absolutely there's evidence that anabolic steroids can increase the glomerular filtration rate or glomerular pressure, and that there's definitely evidence that anabolic steroids can cause damage to the glomeruli, and that's what's filtering your urine. That would not be directly related to oxalate. That would not be related to kidney stones, but just in general kidney damage. If you damage the glomeruli, you can have leaking protein into the urine. It's not a direct effect on, again, calcium oxalate kidney stones, but it is important to realize that. I will switch it a little bit and talk about another type of steroid, which is the glucocorticoids, or we'll say the glucocorticoids, or really they're kind of catabolic steroids in a sense, which are your like hydrocortisone, your prednisone and things like that, used for inflammation. Those are known to promote calcium absorption. And there is some concern that those could promote, because of the excess calcium, there is some concern that calcium oxalate stones are going to be more likely in a patient that would be on an anti-inflammatory steroid, a glucocorticoid for some period of time. So yeah, I mean, these are all really good questions, and I've done my best to answer them. They're actually pretty complicated if you dig into the literature. There's a lot of evidence out there that points you in a lot of different directions. But that's kind of my summary of what I found. And again, I'd like to thank everyone for having this opportunity to actually answer these questions. And a lot of these webinars don't have follow-up questions, so I think it's a really excellent idea to include these to really enrich our minds. So thank you, and have a good day.
Thank you, Dr. Adam Van Wort, for addressing the queries of the participants. Now that we have completed the first session for the day, it's time to offer a vote of thanks. I, Dr. Shailendra Kumar Mahanta, Professor, Department of Pharmacology and Pharmacy Practice, would like to thank the management and the principal, Dr. Sheikh Abdul Rahman, for providing me the opportunity to offer the vote of thanks for the session. I would like to thank the chairperson for the session, Dr. Chandubabu Rao, Principal of Priyadarshini Institute of Pharmaceutical Education and Research, Guntur, for his valuable presence for the International E-Conference Session 1. I would like to extend my heartfelt thanks to Dr. Van Wort on behalf of the management, principal, faculties, and students of Nirmala College of Pharmacy for accepting our request for conducting the session for the International E-Conference sponsored by AICT. I would also like to thank Dr. Ajay Bomareddy, co-coordinator for the event from Wilkes University, USA, for facilitating the arrangements for session 1 by Dr. Van Wort, Associate Professor in Pharmacology and Toxicology at Wilkes University. I'd like to thank all the organizing committee and all the faculty members for their cooperation in the smooth conduct of the session 1. I thank the participants of the AICT-sponsored International E-Conference on Pharmacy Practice and Therapeutics for closely following the session so far, and look forward to your active participation in all the sessions. Thank you all. Have a good day.